Welcome to QD Video, brought to you by RheumNow.Live. Rooms like us go to meetings like this, RheumNow.Live, check it out. Our case today is called the undertreated RA patient. She's a 28-year-old female who's had rheumatoid arthritis for about 3.5 years. When she was first diagnosed, she went to a rheumatologist who put her on methotrexate, put her on some low-dose prednisone and non-steroidal. And then in the next 2 or 3 years, the patient sort of went in and out of care based on insurance, would occasionally entertain the idea of going on a new therapy or a higher dose. And even though the methotrexate was worked up to a total of 20 milligrams per week, it would intermittently go between 10 and 20 based on who was prescribing, sometimes a primary care, sometimes a rheumatologist. And basically, this is the undertreated RA patient coming to you 3.5 to 4 years later, and you're now left to right the ship. And it's not pretty, meaning that we're looking at positive prayer sign, contractures of the PIPs like this, swan neck deformities, a limited grip. The patient's unable to make a full fist. This is about as far as she can go. She cannot get her fingers into her palms. She has evidence of erosions on x-rays. Someone even did an MRI, not sure what that was about, showed more erosions, not surprisingly. So she comes in at this point undertreated with feeling very poor, pain on a 0 to 10 scale of 7, and hurts kind of in many places, fingers, ankles, wrists, knees. And the question is, what are you going to do? She's currently on 10 milligrams of 10 milligrams of methotrexate a week, no prednisone, and meloxicam once a week. So I think you need a strategy. And my strategy for dealing with things like this is, number one, start all over. Clean the slate, do a total reassessment. If you think you need x-rays, do them. If you think you need serologies, do them. This patient has positive rheumatoid factor and CCP. I'm going to check and see how high, because obviously a higher, tighter seropositivity means more and is more dangerous in someone like this than a barely positive rheumatoid factor or CCP. Could she have another diagnosis? And I think that that's possible, but honestly not likely. And you might want to consider that. Number two, forget the past, meaning don't dwell on the fact the patient has been undertreated. Boy, your doctors had no idea what they were doing. Boy, you really screwed up by not going back and not being steady with one doctor. Boy, so it's spilt milk. It's gone. Basically, you declare to the patient you have really severe disease. The ability to get back function and improve pain and reduce swelling is going to be limited. The ability to correct deformities is going to be close to nil. So again, forget the past, but tell her where we are. Tell her in no uncertain terms, this is mild disease that merits any kind of therapy, or this is aggressive disease that merits only aggressive therapy. She has aggressive disease. So she's going on methotrexate and some other combination agent. She can go on triple DMARD. She can go on pills and take a JAK inhibitor plus methotrexate. She can go on methotrexate plus a biologic, hopefully a TNF inhibitor to start with. Given those options, this patient prefers pills. I won't say what she got into, because ultimately it's going to be determined by her insurance what pills she's allowed to take, what biologics she's allowed to take. But she has aggressive disease. We're going to be very aggressive with her. We told her that. That means she needs to be seen here every 4 to 6 weeks. If she's not responding right away, we're changing right away. I'm not waiting 6 months for her to have a response to any therapy I use. If she's not hitting a home run or a major change at 6 weeks, well, guess what? We're changing. Right now, her CDI score is 20, and she has 10 swollen joints, and she's one of these patients who actually doesn't say ouch when you squeeze on her joints. So she's got a lot more swollen joints and tender joints, which scares me even more. But the idea is, if at 6 weeks, if she's not made a major change, a 50% reduction in her CDI score, a 50% reduction in her swollen joint count, we're moving on to some other therapy. And you need to set goals, like what is expected as a result of this more aggressive approach, as far as mobility, as far as damage, as far as the long-term consequences of disease driven by inflammation. And tell her that the reasons you have to be aggressive is that you can avoid further long-term consequences. Not sure what we're going to do as far as deformity. Deformity is often a train that's left the station, meaning once they start having deformities, you can use the most aggressive therapy available, and it's not going to change the natural course of disease in that deformed joint. That early swan neck is going to become a fused swan neck at some point. Doesn't matter whether you control synovitis and drop their SED rates and CRPs to 0. So again, maybe it's possible, but it may not be possible. These are the kind of cases that make you lay awake at night. Why didn't this person get more aggressive care? And what can I do to change the outcome? Tune in for more QD videos. Take care.